All right, I'll go ahead and keep admitting folks as they join. In the meantime, let's go ahead and get things started. All right, so for tonight's quarterly meeting, we have quite a few presenters. There is myself, the Director of Operations for Healthcare for All Minnesota. We have Maggie Emery. She's on the Healthcare for All Minnesota board and the Executive Director of Protect Minnesota. We have Dr. Ken Engelhardt, a former board member and co-chair of our Coalition Building Committee. Don Pulkkinen, who's also on the board of Healthcare for All Minnesota. He's our Secretary Treasurer and co-chair of the Legislative and Policy Committee. And then Ann Jones, our Vice Chair of Healthcare for All Minnesota, and also chair of our Organizing and Base Building Committee. And then finally, our chair, Rose Roach, who has contributed quite a few information to tonight's meeting.
This is Ann. I'm a retired registered nurse, and I'll just run through the agenda for this evening. So Rose will be here being herself because we've had a last minute change in our agenda. We had a couple people pinch hitting for Rose, but she is able to be with us this evening. We're going to start out with a presentation by Maggie Emery, and then we'll get remarks from the chair by Rose herself and an update on the Minnesota Health Plan campaign. And then Rose Bahia Manasra and Don Pulkkinen will give us reports on the lobby day that we held March 10th, past March 10th at the Capitol. We have a little time for Q&A, assuming that our material goes as planned. And then I have some very important announcements at the end. And then we'll wrap up with Bahia. So go ahead, Maggie. We are privileged to have Maggie present some information this evening about a topic that we think is important to continue to pay attention to as we try to work with groups, a variety of groups of people in our country working to fix how we pay for healthcare.
So that's right. Yeah. Thank you, Ann. Thanks, Bahia. It looks like those slides are up. Thanks. Can everybody hear me? Great. Well, good evening, everyone. My name is Maggie. As Bahia and Ann stated, I am on the Healthcare for All board, and I'm also the executive director of Protect Minnesota, which is the state-based gun violence prevention nonprofit here in our state. And I'm going to be chatting with you all tonight about DEI, centering equity in the fight for single payer here in Minnesota. We think that this is a super important topic as the federal administration pushes back on DEI, because we know that this work can't happen successfully if we don't continue to integrate it and actually double down on our commitment to DEI as a strategy and as a crucial part of our work for universal healthcare access in our state. So let's go ahead and dive in. Bahia, if you wouldn't mind switching to slide number 2, that would be really helpful. So why are we talking about DEI in the fight for single payer here in Minnesota right now? A few reasons. So first, persistent health disparities demand action. So folks who benefit from DEI policies, communities of color, low-income populations, rural residents, LGBTQ plus folks, and people with disabilities continue to experience worse health outcomes in our current system due to systemic inequalities that's only been highlighted and deepened by the COVID pandemic and kind of the ensuing upheavals in our healthcare system. So it's a question of DEI now because we need it now in our healthcare system, right? We also are focusing on DEI right now because attacks on DEI that we're seeing at the state level, at the federal level, undermine health justice. They threaten inclusive policymaking and equitable access to healthcare. The time for us to defend DEI in this work is right now. We have to defend the role of equity in shaping just healthcare policies, including single payer healthcare. 3, single payer has to work for everyone. A universal healthcare system will only be truly universal if it's designed with marginalized communities in mind. If we write a blanket healthcare policy that we think is really, really great, but we do it without paying special attention to the way that some communities are already marginalized by the healthcare system, it's very likely that that blanket policy will continue to reinforce those existing inequalities. So when we enact and write healthcare plans, healthcare legislation, we need to make sure that we're doing it with attention to the disparities that already exist in the healthcare system. And thanks for that question. I'm sorry, I should have explained, and we'll get there in just 1 second, but DEI stands for diversity, equity, and inclusion. And I will have some more time for questions at the end as well, but feel free to pop things in the chat, and if I miss it, Bahia, if you wouldn't mind just keeping an eye on there for me as things kind of emerge, I would really, really, really appreciate it. A couple other things. Sorry, Bahia, will you go back to the last slide? I apologize. Changing demographics and political momentum. So the US gets more diverse every single year, and policies have to reflect the needs of a changing population. This policy cannot be universal if it's not written for the way that the population looks now. And here in Minnesota, we have a very strong progressive advocacy movement. We had like 115 people registered for this call tonight. We had 130 people at our advocacy day. There's a lot of people who are really wanting to get involved in advocacy right now. This is a moment to push for inclusive single-payer legislation that works for all communities across the board. And finally, we're focusing on DEI, diversity, equity, and inclusion now because equity builds stronger movements. Successful advocacy requires broad coalition, and these kind of policies ensure that all voices have a place at the table. Inclusive organizing strengthens public support and makes policy change more durable. So we simply cannot get this done if we don't do it to an eye for including everyone who's going to benefit from a universal single-payer healthcare system. Okay, next slide, please. So let's dig in a little bit more on what we mean by each of these points. So diversity, equity, and inclusion. So first, number one, what is diversity? It means ensuring that all voices, and especially marginalized groups, are represented in the movement. So it means that voices, experiences, and leadership of historically marginalized communities are actively included in shaping policies and strategies. It's not just about numbers, it's about true representation of individuals from these communities and engagement in the movement from people of different races, ethnicities, income levels, abilities, genders, sizes, backgrounds, etc. Why it matters in single-payer advocacy. The people most impacted by healthcare inequalities, as I already mentioned a little bit, BIPOC communities, those with disabilities, rural residents, immigrants, LGBTQ plus folks, low-income workers, they have to be at the center of the movement because these are the communities that are going to benefit the most from a single-payer healthcare system. If our movement is dominated by those with more privilege, like white folks, middle and upper class folks, it risks overlooking the unique barriers faced by marginalized groups. Movements that fail to represent diverse perspectives risk losing political momentum because we won't reflect the full breadth of those who need healthcare reform the most. And I apologize, I'm actually on the Amtrak headed to Minneapolis from Chicago, so you might hear a little background noise. I apologize about that. So now that we've established what diversity is a little bit, how do we prioritize it in the movement right now? So leadership representation, we need to ensure that spokespeople, policy experts, and decision makers in our movement reflect the communities most impacted by healthcare justice. Outreach and engagement, we need to really work hard, each of us, and as a movement, to build relationships with grassroots organizations that are representing marginalized groups, rather than expecting them to come to us, right? It's on us to do the outreach and bring those organizations and groups into the movement. Culturally competent messaging. So we need to make sure we use language and narratives that resonate with different communities rather than relying on a one-size-fits-all narrative. And finally, accessibility. So we need to make sure that our materials, our meetings, our actions are accessible to people with disabilities, non-English speakers, folks with limited internet access, kind of all of those pieces. And it's an ongoing journey, right? Like we certainly are not doing all of this right now. There are things we could be doing a lot better at, but these are goals for us to move toward as a movement and as an organization to ensure that we're really practicing those DEI values that we hold. Okay, that's diversity. Will you please switch to the next slide, Bahia? Okay, so that's the D in DEI. Next, we'll talk about the E, which is equity. So what is equity? Equity is recognizing that some communities face greater systemic barriers to healthcare access. So we don't all start at the same starting line to get the race, to finish the race of getting access to healthcare, right? Some of us start here and some of us start way further behind, maybe because we already have a disability that's going to cost a lot more money to treat, maybe because we're from a low income community, so we can't afford to get preventative care. Maybe it's because we live in rural Minnesota and we don't have regular access to a doctor who lives close by. So not all communities face the same barriers to access. So what does that mean? So equity goes beyond equality. Equality assumes everyone needs the same resources, while equity recognizes different communities have different needs based on historical and systemic injustices. True healthcare justice means giving people what they need to achieve the same healthcare outcomes, regardless of where they start, right? So somebody who starts here needs more to get to the finish line than someone who starts here. So why does it matter in single payer advocacy? Without intentional equity measures, single payer system could still reinforce existing disparities. So, for example, rural communities may lack access to hospitals and specialists. Immigrants, indigenous folks, people of color may continue to experience medical racism, bias in care. People with disabilities might still struggle to get accommodations. A single payer system has to be designed to actively correct these disparities and not just assume that making healthcare free at the point of service will solve everything, right? So how do we do that? How do we prioritize equity in this movement? One, data-driven policy. So we need to ensure that our healthcare policies, whether it's the Minnesota Health Plan or the policy steps we take to get there, analyze racial, economic, and geographic disparities and include targeted solutions. Community-led solutions. So we can't be the ones doing all of this data analysis and all of these suggestions. We need to work directly with impacted communities to design policies that meet their needs rather than assuming policymakers know best. Although our policy champions are wonderful and we're very lucky to have them, we need to make sure that in the shaping of policy, we include impacted communities. Equitable resource allocation. So we need to make sure that rural clinics, community health cares, indigenous healthcare services, et cetera, receive equal funding and support in a single payer system. And finally, anti-racism and anti-bias training. So we need to make sure that medical professionals who are actually dispensing this care are trained to address racial disparities, medical bias, and cultural competency in care. Okay, that's equity. Bahia, if you wouldn't mind switching to the next slide. So finally, that's the D and the E. What's the I in inclusion? The I, or what is the I? The inclusion piece. So inclusion is making sure that our policy solutions are shaped by those most impacted. So inclusion in healthcare advocacy, again, we talked about this a little bit, but it goes beyond having diverse voices at the table. It means that those affected by healthcare injustice have real decision-making power in shaping solutions. So they're not there as a token, they're not there in name only, they're there to advise and truly have decision-making power. It's about shifting from token representation to active leadership by people who have firsthand experience with healthcare barriers. Why does it matter in single-payer advocacy? So a few reasons, right? People who experience healthcare inequalities firsthand understand the problems best and therefore can best help to design the most effective solutions. Without true inclusion, single-payer policies risk being designed by policymakers and advocates who have the best of intentions but don't fully grasp the lived realities of marginalized communities. Top-down policymaking often reinforces systemic barriers, even in well-intended reforms. So a few examples: if rural residents aren't included in policy designs, their unique barriers like hospital closures, transportation issues, provider shortages might be overlooked. If immigrants and non-English speakers aren't consulted, a new system may fail to provide language access and culturally competent care. If disabled people aren't involved, accessibility barriers may persist in the new healthcare structure. So we really need all of these voices and more at the table to make sure that our policies are designed with intentionality around inclusion. So how do we ensure inclusion in the movement? One, center lived experience and leadership. So I know I've touched on this a little. We need to make sure that we're uplifting BIPOC leaders, disabled advocates, LGBTQ plus organizers, low-income community members in policy and campaign leadership roles. And we need to, make sure that we're compensating folks for their time. Community-led policy development. So we need to make sure that we're doing things like listening sessions and town halls in the communities that are most impacted. And we're using, governance models, policymakers work in partnerships with our partner organizations and affected communities. We need to make participation in this movement accessible and equitable. So, we need to do a better job of making sure materials are available in multiple languages and to folks with disabilities, and things like childcare, transportation assistance, so that folks who can't make it out to things like Day on the Hill or onto a call have more easily the capability to join us. And we need to measure it. So we talked about diversity, but we need to measure inclusion as well. So not just how many marginalized people are in the room, but who is making decisions and who is holding the real influence over the policy process. And then we need to track. So we do the inclusion piece and we make sure that there are marginalized voices in the room as decision makers. We need to track whether those community-driven recommendations are actually included in policy drafts and implementation. Okay, Bahia, slide 6, please. Okay, so how do we build inclusive advocacy? Center the voices of those directly impacted, use accessible language and materials, build coalition with diverse groups. So there are 3 big takeaways. Those are the 3 big takeaways. I know that I've said a lot and I've said it very, very fast. It's kind of my problem. I once had someone say to me during a presentation, Maggie's goal is to fit as many words into one space of time as she possibly can. But those are the 3 big takeaways. Center the voices of those directly impacted, accessible materials, build coalitions with diverse groups. Okay, slide 7, please. Can you all see it? You can
Yep.
see it? It's just me that can't see it. Oh, that's okay. Okay, because here.
Yes, the case study is up.
Perfect. So, provide a specific example, and we're not going to do like a share out loud, but I'm going to leave it for you to kind of think this through for yourself as an example of how DEI practices may come up in this work and how we should think about it. So case study, a single payer system has just been enacted here in Minnesota. A state task force is meeting to community programs. They have to choose between 3 proposals. 1, expanding a rural hospital program to address critical care shortages in rural areas. 2, providing and culturally care for training for so far, the Minnesota Health Plan, we only have enough one program this year. The others will repeat partial funding, but they can't be fully developed. So we really only get to choose one. So think about how those would be.
Oh no, it looks like Maggie accidentally hopped off or dropped off the call.
We may have lost her. She's on the train coming back from Chicago, so we may have lost Maggie. Do you want to go forward to the next slide, Bahia, to see what more information is part of this presentation?
Oh, it looks like she was towards the end. So she has some reflection questions.
So she's asking us to think about some questions that we do struggle with because we are a little bit lacking in good ways to reach out to a variety of groups. You can see that most of us are kind of, middle-aged or older white people. So how can we, and we talk about this and we ask everyone to think about ways, and maybe you have suggestions for ways to be more inclusive of other groups than just a majority white culture in that is prevalent in Minnesota. Looks like Maggie may be rejoining us. Maggie, can you hear?
Can you hear me?
Okay, we're at the reflection questions. I'm just kind of reviewing them for people. Do you want to go ahead? How can each of us as individual advocates make sure that our advocacy is inclusive? Go ahead, Maggie. I'll let you take it back.
Yes, I'm so sorry. I hit a little bit of a dead zone here in Amtrak country. I gave you a little more thinking time than I had anticipated. I apologize.
I was commenting that a lot of us are majority white culture, members of the majority white culture, and we do struggle with our ability to reach out and looking for ideas.
Right. Okay, so let's go back to the case study if we could, really quick.
Oh, sure. Go ahead.
And we'll just finish that reflection now that you've had lots of time to think about it. So, think about for yourself, okay, which program did I choose and why? So some reflection questions for you around that. Did you automatically lean towards a program that reflects your own background and experiences? Did you consider the historical barriers each group faces in accessing healthcare? Did you assume one issue was more urgent or important without considering the long-term systemic impact? So there's no right or wrong answer here, right? Like all of those programs are really important and deserve funding. But in thinking about them, we, as DEI enactors in this space, we need to ask ourselves not just what seems most important to me, but, what is most important to the community and to marginalized groups, and what will the long-term impact be? Okay, and then you can go ahead and switch over to the key takeaways slide there, and I apologize again for my delay. Okay, so key takeaways. Bias affects decision making even when we have good intentions. Healthcare justice requires us to think beyond our own experiences and recognize historical inequalities. A truly equitable single-payer system must be designed with input from all marginalized communities, and no group should be left behind. So a few reflection questions for you around that, which it sounds like Anne already dove into. How can we as an organization make our activism more inclusive? And how can each of us as individual activists make sure that our advocacy is inclusive? Okay, so that's all I have for you this evening. But I'm happy to answer any questions that you may have if anything has come up for you. And if I know the answer, which I may not.
So we put a Q&A at the end, but Maggie does have another commitment this evening. So we want to allow a couple of questions right now, if people have them.
I was just wondering, since I'm new to being more active in this group, and I don't know a lot of the history of what you've been doing recently, I just was thinking of ways to connect with groups. Do we do tabling at different events that include, diverse populations? Would that be, one way to maybe get the word out? Just thinking about that.
Yeah, Michelle, I love that idea. And I think we're well kind of into that mindset. We do table at Pride, so we do a lot of interacting with LGBTQ folks during that, and get them pulled into the movement, talk to them about their disparate access to healthcare. We also table at the state fair, which is has a very diverse group of attendees. So we are able to connect with folks there as well. I definitely think there's space for us to do things like Freedom Fest, which is an East Side event with the Hmong community in St. Paul. Like, I think there's more opportunities like that for us to think about taking advantage of too. And I love that thought.
Mm-hmm. Rose has a question or a comment?
No, not a question. I just wanted to add, because I haven't had a chance to tell anybody this, but yesterday Dave and I did some tabling at an event over at Copal, who is one of our partners that works with the, Latinx community. And it was a town hall with the Attorney General about the Medical Debt Reset Act. But they had asked us and invited us actually to come back, and they're going to work with us to translate our brochure and some of our information into Spanish. So we have it in both Spanish and English. And they asked us to come and spend a Monday and Tuesday really tabling at their workers center, because those are the 2 days that they have a large group of their members that come in around the getting driver's licenses and studying and things of that nature. And so they said they get a lot of traffic on those days. So we're thrilled that they want to partner with us. And that's another opportunity for us, again, to reach out and build relationship with a community that is most definitely harmed by this current system.
Good to know. Thanks. Thanks for that
Awesome,
connection.
Rose. That is super exciting news. Yeah.
Any other questions for Maggie?
Anything else
before
from
she-
folks? All right. Well, thank you all so much for your time. Oh, sorry. Was there something?
Oh, well, I was thinking, while they were on those three different factors, sections of healthcare needs, on that number one about rural areas in Minnesota, we're a huge state, and we have, most of us is a rural area as far as geography goes. I was thinking back to the concept of bookmobiles, and why not have a roving clinic, van that could go around and get to the people rather than expecting all the people to come to you. It seemed like that would be a more efficient way of taking care of especially chronic conditions and so on. But my other thing was, I was thinking there are, and this goes back to what Rose was just saying about groups. There got to be groups working on this. I know there are translators in hospitals and things, for people, but I don't know if there is a group that does that. Or anyway, if we could get a lot of groups to join us as a group for that particular area, but to push for this Minnesota healthcare plan.
Yeah, I think those are both really great ideas. And I do know that we do have mobile health clinics in some counties. I'm unclear if it's a statewide program or not. But I think that's a great idea and definitely deserves more funding. All right, final questions here.
Okay.
All right,
If-
well, thank you so
if
much,
done.
everyone. I apologize that I have to hop off here and head onto my next call. I really appreciate your time and attention to this issue. And feel free to reach out to me at any time with any questions that may arise through the rest of the evening too about this. Thanks, everyone. Bye-bye.
Thanks so much.
Thank you, Maggie.
Next up, even though the slide says that Ken Engelhardt will be presenting for Rose, Rose is here with us. So she can speak for herself and give us remarks from our Chair of Healthcare for All Minnesota. Thanks, Rose. Go ahead.
Yeah, thanks, Ann. So what I was supposed to be doing was attending. Our Attorney General is having a town hall tonight at the North St. Paul High School, which is not too far from my house. I'm in Woodbury, and he's got the Attorney Generals from Illinois and Arizona with him, and they are talking about executive federal overreach. And so Dawn Tuvison, who is of course another one of our activists and leaders here in Healthcare for All Minnesota, lives by me, and we were going to go over there and do that tonight because we felt it was a civic duty to attend since it was so close to our home, and we couldn't get anywhere near the place. I mean, absolutely jam-packed. There are lines outside that door. I think if we'd have gotten in, we would have been standing room only type of a situation, which is so awesome and great that so many people are engaging, but we couldn't even find a handicap place to park. Everything was was full. So I dashed home, and Ann wouldn't give me the night off and said, nope, you're doing your part since you're available. So Here we go. That's why I thought I was going to be gone. But anyways, I just wanted to say for a couple of minutes that really the work of Healthcare for All Minnesota these past few months has really been twofold. Executing a successful lobby day on March 10th and recruiting organizational partners to officially join the Minnesota Health Plan campaign. You're going to hear more specifics about each of those projects tonight, but I just want to say how incredibly proud I am of our scrappy little nonprofit, our amazing Director of Operations, Bahia Manasra, our strong partnership with PNHP, especially their Executive Director, Jen Crawford, and their co-chairs, Drs. Brian Yablon and Jenny Zhang, and the power that we're building with all of you and numerous labor unions and community organizations to achieve our goal of passing and implementing the Minnesota Health Plan within the next 5 to 8 years. We have come a long way and should take a moment to celebrate what we have been able to accomplish over these past couple of years. Thanks to everyone who was here that participated in our lobby day on March 10th. We were on the Hill. Legislators knew it. They knew us, and they wanted to hear what we had to say. We did, in fact, have an impact up there. No question about it. Thanks also to those connecting us with organizations who we're building relationship with to grow the organizational partnerships that are going to be needed to win the Minnesota Health Plan through the statewide multi-year campaign plan that we've developed. The campaign partnerships continue to grow as more and more organizations want to be part of our campaign that brings about real change to a healthcare system that has clearly lost its mission, healthcare for people, not wealth care for corporations. As we continue the work of refining the MHP campaign plan while pressuring legislators to begin the work of removing those privatizers from our public health programs and start building our public health infrastructure, it's also important to take a moment to reflect on the incredible progress made to date and be grateful for the support of one another. Thank you all for remaining committed to this effort. We cannot and should not run from these very people-centered policies we espouse to enact just because the other side has decided to use fear tactics to make common sense and human decency somehow seem radical. We cannot let fear win. So with that, I'm going to go ahead and just transition right into a couple of minutes to give you an update on the Minnesota Health Plan campaign. We laid it out for you at the last meeting, so you know the particulars of what we are looking to work on. So let me just give you an update. The organizations that are listed on the screen here have officially signed on and committed to the campaign. We're very excited to have these organizations already saying we're in. We want to be supportive of the campaign. We want to provide resources to help win. So they are all going to have seats on the steering committee once we get the steering committee up and running. So you can see here we've got some labor organizations. We've got some community organizations. COPAL was the first one to sign on. We are so grateful to that organization and all of the partnership work we are doing together with them. We just learned yesterday that the Minnesota Nurses Association voted to join the campaign, as did the St. Paul Regional Labor Federation Retiree Council, and Ann and I will be firming up the commitment by the Minnesota Association of Professional Employees, which is MAPE, next month when we do a presentation there, but they're already at the 99% we're in level because they've already assigned people to the steering committee. So we're in good shape there. You can go to the next slide. We're continuing the recruitment of organizational partners, campaign partners. I have met once with Education Minnesota. We're going to continue conversation with them. I just see the breaking news that President Trump has signed an executive order to dismantle the Department of Education now officially. So I'm sure that Education Minnesota has its hands full at the moment. So I think I'll wait until after session to revisit with them. We continue to work to build relationship and outreach with Isaiah. We heard that Land Stewardship Project has put healthcare sort of back on the list of things that are concerning to their organization, their members, and their farmers in particular. I got an invitation to keynote a League of Women Voters annual meeting here coming up in May. So hopefully we will continue to bring more and more of the League of Women Voters chapters into the movement. We are talking with the Minneapolis Federation of Teachers, Local 59. They are very interested in getting involved, as are the Regional Labor Federation retirees from Minneapolis. We're continuing, again, conversations with the Farmers Union, the State Faculty Association, SEIU Healthcare Minnesota, Local 26, and UNIDOS and Veterans for Peace. So lots of good work is still continuing, everybody. Lots more to do, but we're making inroads. You can go ahead and to the next one. The campaign steering committee is going to be comprised of up to 2 representatives from each of the organizational partners. We do not yet have a firm date for the first committee meeting since we are continuing the recruitment of organizations to join. We do know that the work of the steering committee is going to be focused on power mapping the current landscape to determine who's with us, who's on the fence, who opposes us, and use that to continue developing the campaign plan as it relates to focus and future actions. The steering committee also needs to build a 12 to 18 month calendar with identified goals and metrics for tracking our progress, define campaign roles for partners, get the campaign committees up and running with suggested projects that each committee should prioritize, develop a 2026 campaign budget, and figure out a fundraising structure as well. 2025 will really be focused on building out the campaign plan to include more specific details for each component of the campaign. You can go to the next slide. If you believe that there are other organizations that we should be reaching out to, please let us know and help us get connected to that organization. We're happy to do a presentation on the Minnesota Health Plan campaign plan and build relationship with organizations who would see that involvement in a major campaign to change how we finance healthcare so as to take the profit motive out of the system and refocus it on patients and providers as something that would be beneficial for their organization and their members. Please contact Healthcare for All Minnesota, and we'll do what we can to bring them into this campaign. You can go to the last slide. We really are building out this campaign. It's real. People and organizations are excited to be part of the campaign because it's centered in our common humanity, in our commitment to public health, and our belief that healthcare is a human necessity and therefore must be recognized as a human right. So we are getting there, everybody. Thanks for all of your support. And that's sort of where we're at right now, and hope to have much more to report at the next quarterly meeting.
Thanks so much. Bahia, do you think you could go to the main slides and go to the picture of our Lobby Day event? Yeah. So we had a standing room only crowd for our first in several years, 2025 Healthcare Lobby Day on March 10th. You can go ahead to picture the Capitol, which I have to laugh because it's an older picture. You really can't park cars in front of the Capitol anymore. The Healthcare for All Minnesota and Physicians for a National Health Program Minnesota work together on this event. So we're going to hear from Bahia, our Director of Operations, on with the kind of an overview and a summary of the work that we did to create and pull off this event. And then we're going to hear from Don Pilkinen, who is our Healthcare for All Minnesota Secretary Treasurer and co-chair of the Legislative and Policy Committee, who will report on the actual legislation that we pressed for with this event. So go ahead, Bahia, you are on.
Wonderful. Thank you, Anne. And hi, everybody. My video was working earlier, and for whatever reason, it decided to stop about 20 minutes ago. And so my apologies that you can't see me anymore, but you can hear me. So I'm going to go ahead to the next slide just to talk a little bit more about our phenomenal Lobby Day. So Healthcare Lobby Day 2025 was a huge success. We had 154 people register, over 100 legislative visits with both legislators in the House and in the Senate. Over half of the 67 Senate districts across the state of Minnesota were represented. And we also had a wonderful partner in Education Minnesota They were really, really gracious with lending us their downstairs meeting space for free. And it was really kind of them. We were not anticipating anywhere near the number of registrants that we did get. It's good. It's good to have more and to have a lot of interest. But unfortunately, we ran into the little snag of not having as many chairs as we would have hoped for. But we're just really grateful to anybody that attended Lobby Day that's on this call tonight. If you had to stand for a brief period, we're really sorry about that. But we will tell you that we are working to ensure that we have a much larger space for our future Lobby Days. I also want to go ahead and share some photos. There we go. So here are just a handful of the many photos that were taken in Lobby Day. In the upper left-hand corner, we have the Executive Director of Physicians for a National Health Program, the Minnesota chapter. This is Jen Crawford. She was presenting out to the group. Right next to her is Senator Sandy Pappas, who represents St. Paul, with some of the HCAM and PNHP constituents that met with her. And then in the upper right-hand corner, we have Representative Tina Liebling presenting in front of Healthcare for All Minnesota and PNHP attendees. And then in the middle, on the left-hand side, we have Majority Senate Leader Erin Murphy, who represents St. Paul, with many of her constituents that attended. We also have Representative Pinto also joining that photo. And then in the middle, we have, it's kind of hard to see because he's a little tucked in the corner, but that's Senator John Marty speaking about healthcare equity and all the great legislation that folks lobbied for on March 10th. And then I also added a couple other viewpoints of the Education Minnesota space just to show you how packed that room was. We're really grateful that we had such a wonderful turnout. And then we also have one final photo that I included of Senator Pa with one of our board members, Dave Garibaldi, in the Minnesota Health Plan t-shirt. So we have tons of more photos. We've been sharing them across social media. If you attended and have photos yourself, please go ahead and share those with us. We want to make sure that we can document all the great meetings and all the wonderful memories that were created on March 10th. All right, I'll go ahead and pass this over to Don Pulkinen.
Thanks much, Bahia. I just want to begin by saying that it was very gratifying for me to be a part of the wonderful team that you helped bring together that made Lobby Day such a great success in our movement towards the Minnesota Health Plan. And thanks again for your leadership and pulling this together. I just want to go on to relate what what the legislative part of Lobby Day, how that came about and why. The basis of our campaign for the Minnesota Health Plan, which is getting health care for all by removing the HMO and PBM middlemen from healthcare delivery, was clearly voiced at the HCAM and PNHP Minnesota Lobby Day, March 10th, where, as you reported, Bahia, 100 constituents met with legislators on 2 bills that will begin the removal process. The bills are the Patient-Centered Care Bill, authored by Senator John Marty and Representative Tina Liebling, to remove HMOs from medical assistance and Minnesota Care, and instead directly pay hospitals and clinics to save money by cost containment. And the Pharmacy Carve-Out Bill, authored by Representative Tina Liebling, to remove commercial PBMs from the HMO contracts of those programs that have the state be the drug purchaser for fair reimbursement to independent pharmacies that are struggling, and to keep those pharmacies in business on Main Street. Meanwhile, medical debt forgiveness for roughly 250,000 to 400,000 Minnesotans would be enacted by the Medical Debt Reset Act, authored by Senator Liz Bolden and Representative Kim Hicks. The clarity of the constituents' messaging to deprivatize healthcare delivery was due to the several training sessions on the rationale of the patient-centered care bill titled Minnesota Healthcare Cost Containment, What Hasn't Worked and What Will Work, that was created and organized by a subcommittee of volunteers from HCAM's Legislative Policy Committee. Kip Sullivan led the team at several Saturday morning workshops that developed the evidence-based content of the video training. Monica Acri spent many hours enhancing it with visual effects, scripting it with Kip, and creating an engaging introduction. Dave Garibaldi developed a convenient one-stop shop notice of the training that offered several Zoom sessions, including Kip for Q&A, to fit participant schedules that Dave organized with Bahia. And he also assembled links to the training video for participants to view on their own. And Bahia emailed the notices to our member database in every action. To train constituents to lobby effectively, Jerry Katz offered her training expertise as a former M&A staff to create and present on March 6th and March 8th, prior to the March 10th lobby day, on the do's and don'ts of lobbying, which ended with Rose presenting the bill's talking points to enable constituents to make their case in limited time with their legislators. For legislators to have details of the bills for reference after the constituent meetings, Dave and I drafted a leave behind for each bill that was edited by Rose and Ann. To augment the training for Lobby Day, our allies at St. Croix Valley Indivisibles scheduled a timely presentation of the patient-centered care and Minnesota plan bills by their author, Senator John Marty, on February 27th. And Dave arranged with the Indivisibles to have Rose follow Senator Marty with a briefing on the pharmacy carve-out and medical debt reset bills that we would also be lobbying for on the big day. The Lobby Day kickoff on these bills will continue through the legislative interim, with constituents sending letters to their legislators and meeting with them in their districts to keep building the case for the Minnesota Health Plan to replace the HMOs. Lobby Day success, according to positive feedback from participants and constructive responses from legislators, demonstrated our grassroots organizing and educating capacity for the Minnesota Health Plan, which is expanding with the statewide campaign of numerous allied organizations that Rose earlier mentioned. And I'm just really personally glad to have been a part of this tremendous effort in working with this wonderful team.
Thank you so much, Don. Everybody, you can tell how much behind the scenes work went into this event. But Don has kind of hit the high spots on the bills that we support. And I wonder if Rose had prepared some slides that give a little more detail, and we will send those out with the post-meeting email. But I wonder, Rose, did you want to cover the one that we found out about at the last minute and needed to talk with our legislators about?
Sure. I could just briefly tell everyone that back in 2021, there was a bill that was passed, and it happened to be a bipartisan bill at the time because you had the Republicans were in control of the Senate and the Democrats were in control of the House. And Representative Tina Liebling was the chair of the House Health Committee, and Senator Michelle Benson was the chair of the Senate Health Committee. And the two of them managed to put together a bipartisan bill that passed that basically said inside of our Medicaid and our Minnesota Care program, in addition to the medical care going through an HMO or a managed care organization, insurance company, so does the dental program. And apparently, the state of Minnesota has been falling far behind federal thresholds that should be met for people who are in these programs and seeking dental care. And so the bipartisan bill basically said, we're going to give the managed care organizations 4 more years to try and see if they can't do better and get to a place where at least 55% of all of the participants in their plan go to the dentist once a year for at least a regular once a year check-in. And they were provided additional funds to help do that. They were also provided some additional benefit expansion that they could include in their plan program. And they had from 2021 until this year, 2025, the end of this year, to try and reach that 55% threshold. They are not reaching it. It is not, I guess, anywhere near 55%. And so therefore, assuming they don't reach it by December 31 of 2025, the program reverts back to the state. And the state would be set up under this, again, bipartisan legislation to actually hire a single dental administrator who would just oversee the entire program. There'd just be just that one dental administrator. So it would really streamline funding. It would streamline the program. The state would have policy levers to be able to try to figure out how to do better and get more people to see a dentist, to increase reimbursement rates for dentists so that they're more open to being able to see people who are on Medicaid and Minnesota Care. And so we were seeing this, quite frankly, in our movement as a little tiny sliver, right, of a program that was under MCO administration coming back to the state, and an opportunity for the state to show that they can do it and they can do it better and more cost effectively and much more efficiently. So we were kind of seeing that as kind of a test program. And then sort of out of nowhere, right before our, I think it was the Friday before our lobby day, got notice that a bill had dropped in the House and the Senate that would actually give them another 4 years. That would extend them back out again, not have it revert back to the state in January of 2026, and would actually put it back into the hands of the managed care organizations for yet another 4 years. Now, it is both of those bills are authored by our friends. Senator Bolden and Representative Reier are healthcare champions in our legislature. So we were a little bit, surprised and just weren't sure what on earth was going on, but we needed to make it clear that if the industry is able to pick us off on such a small little piece that was going to come back to, state administrative control, then clearly we're in for the battle of our lives just to try to pass the patient-centered care bill, which would begin to, do direct payments for our entire Medicaid and Minnesota Care program, let alone move to eventually the Minnesota Health Plan, right? I mean, this is the industry we're up against, guys, right? We all know that. They're going to fight tooth and nail to keep everything that they possibly can. So we unfortunately had to tell folks that we opposed that carve-out bill, and we wanted our legislators to meet with particularly Representative Liebling to talk with her about what was originally agreed to and why. And Representative Liebling did acknowledge that there was some loopholes that needed to be closed in that 2021 on legislation, and she will be dropping any day now a bill to do just that. And we're hoping that's the bill that will actually now get traction, because it deals with what I guess we're hearing is the main issue, which is the dental association's concern about their reimbursement rates. And that's valid. I get it. They're giving a service. They need to be able to be properly reimbursed for that so that they can continue to provide services, right, and run their clinics. So she's prepared a bill. It's been jacketed. She told me she's going to be introducing it, so we should have a number any day on that. So fingers crossed that we will actually be able to push for that bill, and it will start to deal with what we think is the driving factor behind these two bills that we did not want to do, because we do not want to continue more of the same with the managed care organizations involved in our public health programs. So I hope that makes sense. I didn't mean to talk so long, but it gets a little complicated. So hopefully I explained it in a way that makes sense.
Okay, thanks. Bahia, would you be able to put our slides up, starting with the, that was my visit to, we were literally in the hallway talking to Representative Sensimura, so lobbying means anywhere you can catch them. Next slide. And we will be back next year. Our planning committee is already talking about dates for the 2026 session, and location that we hope to snag something in the Capitol, so we'll have a little bit more space. And it looks like we have some time for questions. Go ahead to the next slide. If people would like to put their videos on, turn your video screen on and join the meeting. Feel free to ask some questions. Use the raised hand, and Bahia and I will watch for raised hands. John Crossan, go ahead.
Yeah, I don't have a question. I just want to make a statement. There was a major meeting today at Hennepin County Medical Center, which was actually run by Ilya Omar, and Kelly Morrison was also there. It was covered extensively by the media. Our CEO of HCMC was there. Head of emergency medicine was there. And there were a number of several patients who were there who testified. And basically it had to do with the fact that at the federal level, they're looking at cutting up to $880 billion out of Medicaid. And so this was an appeal to continue Medicaid as is. And I had an opportunity to stand up and talk about the PCC bill and how it would save us $1 billion in Minnesota. So I got that on the floor. It should have been covered by the media.
That's awesome, John. Thank you always for being our advocate and voice in those rooms. Thank you. I think Bruce has his hand up. Go ahead, Bruce. You're muted, bud.
Anyway, thank you. I've been involved with Healthcare for All for a while, was on the board for a while, and I want to just compliment everybody who was involved in Lobby Day, because I was involved in Lobby Day about 5-6 years ago, and you folks have really come a long way. It was so well organized, a number of people who were involved, the training that went on, it was fantastic. And I just wanted to make that comment. I think the organization is really growing in the last few years, and God knows we really need it.
Thanks. That means a lot, Bruce. I think I would echo that. So many people worked really hard to pull this off, and we were very gratified at the number of people like you, longtime activists, who, you know, continue to show up.
Roger, go ahead.
Okay, thanks for taking my question. Is the governor and the lieutenant governor on board yet? Or are they running and hiding in the corner when we come up with Minnesota Healthcare for All?
Oh, well.
Yeah, I mean, and I don't even know how to answer that question to some degree, right? Because certainly when I was with the nurses and Governor Walz ran the first time and the second time, the nurses were pretty point blank that it's not just about you willing to sign the bill. We need to know that you really mean this and that you'll support it and that you will actually help us make it happen. And he said yes, that he supports it and he will sign the bill and he will help us make it happen. But, I don't know that that's materialized a whole lot. So I don't know what to tell you about that. I think Lieutenant Governor Flanagan was a co-author on the Minnesota Health Plan when she was in the House. So I think she probably is a strong supporter. And and it's funny because I just talked to Senator Marty last night, and he recommended that that the leadership at HCAM reach out to Lieutenant Governor Flanagan, especially as she is, also preparing to run for Senate, and make sure to talk with her about single payer and Medicare for all and things of that nature. So, yeah, I don't know what to say. I don't know if they'd fight it behind the scenes. I don't think so, but it's a hurdle for sure.
One other question, how about Melissa Hortman, the leadership? I gotta believe this is a no-brainer for the state of Minnesota. I'm having a hard time with Republican friends getting on board, but they understand it is a serious problem. So
Yeah, I mean, I think we have work to do inside of the party. I'll be honest with you about that. I think, one of the things that we're hoping to do with the Minnesota Health Plan campaign in our work when we create, the next level of campaign is to get out to all of the Senate districts, start with probably, some of the DFL ones, to just get ourselves up and running with sort of a format, but we have to go into all districts. It cannot just be Democrats. So don't get me wrong. This is about all of us as human beings. Doesn't matter your political, affiliation in any way, shape, or form. But just to try to, like I said, figure out what is a good format. I think it's about listening. I really started, and some of you have been a part of the presentations I've been doing over the last month. I've been trying to start the presentations by saying, let's talk about what do you like and what don't you like about our healthcare system? Are there obstacles, that are preventing you from getting care? And if you could create a healthcare system, what are things you would want to guarantee? What are things you would make sure were part of that system if you were creating it from scratch? And it helps people think about, well, most of the time I get things like, well, we shouldn't have co-payments and deductibles. Well, there shouldn't be things like claims denials. Well, I shouldn't be limited to what doctors I can see, right? Well, guess what? That leads you to the Minnesota Health Plan or to Medicare for All, right? So it's a way to open that conversation a little differently than just kind of like preaching at people about it. And I'm not saying we're going to get everybody, because we're not. You're not going to get everybody on anything. But I do think there's a way for us to open a real dialogue with folks about how we can find some common ground to move this program forward. And we have to do that even within our seated legislators, both in Congress as well as in the Minnesota House and Senate. But I think we can get there. And I think that we also have to put an eye towards candidates. We probably have to do more work with candidates. And again, not telling them to just simply say, sure, I support it. No, they have to run on it. And they have to have town halls on it. And they have to educate their voters on it. And they have to be willing to talk to their fellow legislators about it. It's got to be more than just simply saying, giving lip service and saying, yeah, of course, I support single payer or universal health care. That's just not enough anymore. The time has come. The time has come. We need to start to push it and make it a reality for our future. And we have to start that work now.
Well, I have a follow-up question to that is,
sure.
Given what is going on at the federal level now, do you have a sense of what kind of environment it's going to create that we're going to be working in over the next 2
Mhm.
years? Because I would
Yeah,
think it would lend itself to getting some positive feedback.
Yeah, I mean, you know, in order to do a single payer in a state, you have to get a federal waiver. And I don't suspect we will get a federal waiver for anything that we want to do that like helps people, unfortunately, right now. But at the same time, that doesn't mean we can't be building towards that. So when the tide changes, and I do believe it will change, we will be ready to rock and roll. We will not have to sit back and wait anymore. We will have done all of the groundwork, all of the educating, prepared all of the documents, figured out all the financing, and we can literally just start to move. And so we can use this time to do that work and that base building and grassroots building, so that once we have the environment where we can actually move the bill, then we won't have to like sit and wait for anything. We will just be ready to flip a switch, and we will have thousands of people hitting the hill and demanding that this kind of a healthcare system. And I do think people are looking for hope these days. And we're, you know, I'm sure many of us on the call are frustrated, and many times you feel depressed and not sure what to do. And I totally get it. I have to take like anything in snippets right about now, or I feel like I'm going to have a complete anxiety panic attack. But at the same time, you know, we have to be aware of all that. Don't get me wrong. But at the same time, we also have to band together and provide hope to each other and tell people another world is possible. And we can do this, and we can have something other than a profit-driven healthcare system, even here in the United States of America. And I think the states probably are the place where that innovation has to start, just based on what's happening at the federal level. We probably got to start here.
Well, I think just
so
to
let
follow
me-
up on that quickly is that it seems to me that it should be providing an opportunity, you know, good soil for
Yep.
us to plant the seeds.
I agree. I agree wholeheartedly, Bruce. I appreciate your comments about that. Yeah, Liz, I think had
Oh,
her
let me
hand
recognize
next.
Liz. Mhm.
Yep.
Liz Ward, can you unmute and?
Yes, you're muted. Oh, you're still muted. We can see you, but we can't hear you. There you
Oh, there
go.
we
I guess it didn't click there. So I just wanted to add that at the meeting, at the COPOL meeting yesterday, Rose, Keith Ellison, I was surprised and so happy that he was just like, go, single payer. He was right there. And geez, if he ran for governor or Senate, I think he would be a champion.
Yeah, well, Keith, when he right before he left Congress, the House, he was the author of the Medicare for All bill in the House. He took over as the chief author when John Conyers left the House of Representatives, and he became the chief author. But then that was just in the early year of 2018, and then he decided in the middle of 2018 to run for Attorney General. So that's when it got handed off to Representative Pramila Jayapal from Washington State. But Keith has been a big single payer supporter from day one. He gets it, and he's always willing to stand up and tell people this is where we got to go. Go ahead, Ann.
So the reason I had my hand up was I was going to ask John Hessian to comment about the bill that we picked. We picked the state prescription drug purchasing bill to be allies with our coalition partners on the Minnesota Independent Pharmacy Organization. So go ahead, John. I wanted to let you give us a little update on the status of that.
Can you guys hear?
Yep.
Sometimes this computer doesn't connect right. You all good?
Yep.
Perfect. So, yeah, no, you guys got lucky. You were the day after us at the Capitol. So we were the morning where we had the 9 inches of snow. It was a mess, and half of our participants weren't able to get in, and it was, yeah. Anyway, but we still made an impact. But yeah, so we've got a couple bills going already over there. And it's been introduced in the House and the Senate for the state basically to choose a single PBM. And we testified on Tuesday in the Senate hearing, the Health and Human Services hearing on the bill. And the health plans are nervous. They're concerned. We stayed after the hearing to chat with a few of the senators in the room and to further our cause. And when we came out of the hearing room, they were waiting in the hall for us, and it was 30 minutes later. So they wanted to talk, and they just wanted to smooth it all over. Well, we'll just have the states more money, and then we'll just pass it on to you. And I said, oh, no, you won't. And so, we've got a fight on our hands. But the beautiful thing about it is Senator Abler and Senator Liskey.
Greenhagen?
He's not on that committee.
But he's with us, right?
Yeah, he's somewhere.
He was one of those speakers at the Optum
Yep.
protest.
No, he's certainly with anything that's going to support independent pharmacy. But yeah, he's not on that committee. But
okay,
what's the guy's name? Liskey or something like that from Lawndale. He's a Republican, and he told us afterwards. He said, before this hearing, I would not have said I was in support of this. But after hearing your testimony and thinking this through, and he was almost 100% flipped. And one of our pharmacists from down in his area is meeting with him again Friday or Tuesday or sometime in the next few days here to just kind of go through it again and make sure that we got him. But and then Abler is on board. And so yeah, this is, and don't think that your cause, the healthcare cause is a non-Republican thing, because these Republican representatives and senators are getting hammered out in the rural area because their people are feeling the pain. The costs for insurance are through the roof. The provider networks are disappearing. They can't get what they need when they need it. And so it's a lot easier to drag them into the fold right now than it ever has been. And so, this whole pharmacy bill is probably one of the most, bipartisan things that they got going on over there right now. And so this will be a perfect opportunity if we get this bill passed and the state can just at least carve out the pharmacy part away from the health plans. It is going to real tell as to what the bigger move, the health side of it will be. But I mean, they know we're coming for them, and they are concerned about it.
Well,
because
that's awesome.
people
They should
are
be.
feeling enough pain and the pressure's on. And so thank you guys for throwing your support behind that. But I mean, it's, we're coming. I don't know if you had an opportunity to watch. You should look up my testimony from Tuesday at the Senate committee, because what I did is I printed out a report from 2024 of all the prescriptions that we filled that were below our operational cost. And it's 754 pages with 55 lines on a page, 41,400 plus prescriptions. And I bolted it together, and it's literally, it's 3.5 to 4 inches thick.
Wow.
And that's what I carry with me when I testify now. And the thumbnail of the video on YouTube for that hearing is me holding up the stack, what we call the stack. And I have tabs in it, and where I show them, this much of it was the worst is on the top, and the last page is where we break even on the bottom of 704 pages, and about a half inch of it at 55 lines a page was how deep we had to go before we actually got the cost of the drug back. Then about a quarter into the stack is where we had enough revenue per script to buy a can. And then about 2/3 of the way through the stack is where we had enough revenue to buy a cup of coffee at a typical coffee shop. And you could just see, I did the same thing in the House the week prior and in the Senate, and they were just like, I mean, I just can't believe it.
Mm-hmm.
And you know, and I said, and here's the, just to give you another kind of visual of what this stack means. I said, this is 2/3 of my business below cost. And look, 2 pharmacists and 3 technicians working for 8 months to do the work that is in the stack, including the phone calls, the prior authorizations, the refill chasing, the educating the patients, and all the other things that go along with just filling the prescriptions. And that 8 months of work for 5 full-time equivalents, 2 of them professional pharmacists, for nothing. And that just, you know, they're just like, oh, wow. I mean, it was a gut punch to them. And I said, you know, in the Senate, you know, they have the tables with the kind of raised area in front of the testimony table, you know. So I just said, I just plopped it up on there and I said, I'm going to just lay it right here for you to ponder while I continue, you know, and it just plopped the whole thing down up there, and just, you could just, it was unreal. You could hear a pin drop. Not one of them was thumbing on their phone. Not one of them was, you know, shuffling papers. They were just like locked in. And so the reality is coming. And like I said, I think it's a great time to just throw more coal on the fire and keep pumping it. And you know, the healthcare for all, the whole, you know, that Minnesota Health Plan, that's the big picture. But this is a small piece that's going to really drive a wedge in the door, keep it from latching shut. And so more power to us.
Lucky, I know there's a couple more hands. Thank you, John. We really appreciate the partnership, and our goal for everybody on the screen is to just get the money changers out of our health insurance coverage system and our prescription drug
Program.
system. And
Yeah.
we're starting with our public programs. For everybody who isn't quite familiar with the number of people that involves, 1.4 million people in Minnesota rely on Medicaid and Minnesota Care. So that is a huge chunk of our population who our independent pharmacists would then have access to for filling prescriptions, and who we could bring back under the umbrella of a publicly administered system, help build the infrastructure for a future Minnesota health plan, and save millions of dollars in the process. So
Millions,
I know
it's
we have
it's
some
hundred
important
millions.
announcements
Hundreds
at the end, and I know a couple more questions.
Ann, can I just
And
ask John, would you send
yeah.
me the number of the Senate bill? Because Tina's bill doesn't have a Senate author yet. It hasn't been dropped in so I feel like we're maybe talking about a couple different bills, but I'm not sure. So let me know.
Yeah, Tina's is the full carve out.
Right. And this is something short of the full carve out. Just if you'd say, you know,
This is basically the state contracting single PBM. So instead of Health Partners with MedImpact and Blue Cross with Prime Therapeutics and Medica with Express Scripts and you know, UCare Navitus, all the pharmacy would go through one PBM, and it would basically the health plans wouldn't have any control over who that is or how they relate. It's just basically a pass-through situation. So that number in
dental administrator. Okay.
And for people who aren't aware of the scope of the problem, we've lost 2/3 of our independent pharmacies in Minnesota over the last, what would you say, 10 or 15 years?
10 years.
That's
10 years.
Down 400 and some independent pharmacists down to 140 some. It's an incredible loss, especially to rural communities, which is why we think we can get some support in rural Minnesota.
Go ahead, John.
Yeah, so the bill in the House is HF 2242.
Okay. Thanks.
Carried by Nadeau, who's a Republican.
Yes, I know who he is. Yeah.
And then and the Senate bill is SF 1574.
Okay.
And that's Senator Mann, who's carrying most of our stuff in the Senate.
Yep. All right. Great. Thank you, John, for that. Appreciate it. John Crossan, I think you were next, and we'll take John and Hillary, and then we'll wrap up with questions.
Yeah, John, I really appreciate what you're doing. This is fantastic. I would just like to ask you to please completely remove the name pharmacy benefit managers or PBMs, because that is hated by everybody I know, and I think you'd be better off using a different name.
Then what? I guess I'm not following you.
Well, you talk about turning this over to a single PBM. I'm just asking you to get rid of that whole term PBM because it's hated by everybody,
Yeah,
and come up with a different name.
it actually would be a pharmacy benefit administrator.
Good.
They get a per transaction fee. Yep.
That's good.
Yep.
Sounds good.
No more hand in the cookie jar.
Hillary, you're gonna be the last question we have time for.
Well, what I was going to say is because our influence in the rural areas is so important. Well, and I'm speaking kind of for the DFL, and I would just hope that all the work you're doing to rescue the pharmacies in the in the rural areas, that somehow there would be some PR that would say it's great. I mean that it's nonpartisan, but it's like Democratic people are initiating this. If they are, I don't know if they are, given your work, John, but I'm just thinking that a lot of times we're fighting Republicans. So, and I'm glad that it's bipartisan, but to, give some, heft to Democrats really supporting this work.
Mm-hmm.
So it's more a comment than a question.
That sounds
Yeah,
like
no, and there's great support from both sides of this right now. I mean, it really is coming together pretty quickly, actually. So, we just got to get them to stop fighting with each other about everything else, and we can move on.
Thanks to everybody. Thanks for all the contributions of the presenters and the great questions. I wonder, Bahia, if you could put up the slides with the announcements.
Yes, give me just a sec.
You bet.
Anne, do you see the announcements?
Not yet. One more, I think. And you might have to just click through to get to the bottom of the slide. What I wanted to let people know about is that there are a number of events coming up that have a lot to do with protecting, defending our healthcare system against the assault by the current administration in Washington, D.C. So the work around our legislative priorities is ongoing, that you just heard about. And the bills that we introduced include trying to get the commercial insurance industry out and the pharmacy benefit managers for profit out of our public health coverage programs and go to direct payment to hospitals, doctors, clinics, and local pharmacies. Then we have we are also concerned about Medicaid, our VA health system, and Medicare. And there are several events coming up, and our public health system. On Wednesday, March 26th at 11 a.m., there is a rally to defend the VA health system. It's an informational picketing being planned by the Federal Employees Labor Union with the VA health system. It's on the corner of 54th Street and Minnehaha Avenue, across from the Minneapolis VA Medical Center. If you want to register, there's a link to register for that event, or you can, I'm sure, just show up. at 11 a.m. for that event. On Wednesday, April 2nd at 9 a.m. in the Capitol Rotunda, we are asking everybody to consider participating in this. Is a multi-organizational rally for the Medical Debt Reset Act, which is funding to help pay down medical debt for potentially thousands of Minnesotans. And the legislature needs to allocate some funds to provide to a nonprofit who then are with that seed money is able to buy down millions of dollars in medical debt for Minnesotans. And that we are participating in that in conjunction with a number of organizations, including Isaiah and some other bigger nonprofit organizations. The registration link is on your screen. Again, you could probably show up, but the 9 a.m. time is for a little training. If you register, they'll know who you are, and they can, this event does include legislative visits. So then those visits would be able to be set up based on who registers for your particular representatives. And on Saturday, April 5th, a National Day of Action is being planned by a group called the 5501 website, which is a national 50 states, 50 protests, one movement. We are very concerned about the assault on our public health systems by the current administration, the Centers for silencing the Centers for Disease Control, cutting billions of dollars in funding to the National Institutes of Health for medical research, as well as universities and academic medical centers, the potential for billions of cuts to Medicaid. I think Dr. Crossan mentioned that the potential for as much as $880 billion being cut from Medicaid, completely unsustainable amount of money. That would directly affect healthcare for the 73 million people in the US who depend on Medicaid. And then the drive to privatize Medicare that we've been concerned about for a long time, that you've heard from us about, further draining the Medicare Trust Fund by diverting taxpayer money to for-profit interests. So this is going to be a pretty big day. April 5th, you can go to the 5501 website or the Indivisible homepage and join a protest to the assault on our constitutional republic, as well as our healthcare system. Generally, these start, I've been to a couple already at the Capitol. It's generally around the middle of the day, but go ahead and check those two websites, Indivisible or 5501. And then, as always, let us know of local events that we should promote or help with turnout for the cause of fixing how we pay for healthcare. You've got our website on the bottom of the page for checking the calendar, and then go ahead next. Yeah, this is an event that I went to at the Capitol a couple of weeks ago. I brought my young niece, who I really encourage people to not only show up, but push the point that government exists to serve its citizens. And for younger people, this is their future, and we need to ask for everyone's participation. Go ahead, next slide. I generally include, on the subject of building our base of support and spreading the message, we've got some social media sites that we have a really good creator of posts, and we'd ask you to engage with us on social media and expand our reach. Look at our YouTube channel for information and past presentations. Invite others to join us by sending them to our website and joining our mailing list. It's very simple to get on the mailing list and get information, our monthly newsletters, our quarterly meetings, and calls to action and opportunities to engage and volunteer. Go ahead at my last couple slides are really important websites for lots of great information. Our website, Physicians for a National Health Program, videos on Fix It Healthcare, the One Payer States Organization, which is pulling together the efforts of all the states 20 or so in the US who are working on single payers, healthcare reform. Healthcare Now has good training. The Labor Campaign for Single Payer, our chair, Rose Roach, is also the executive director of that organization. Public Citizen has been in this fight for a long time. Social Security Works, really worthwhile supporting them, both showing up at their events, supporting them financially. They are pushing, they have really strong support for Social Security and Medicare. Healthcare Uncovered is Wendell Potter's Substack site, who he is shining the light on the corporate vultures draining money from our healthcare system. And then the Health Justice Monitor, lots of good policy stuff. Go ahead. That's my contact information if you need to get a hold of me. And this is how you can contribute to help support our work. You can see that a lot of people are working really hard. Bahia, I should let you do the fundraiser pitch since you're so involved in that issue for us.
Yeah, hi again, everybody. Just a reminder, my video isn't working. It stopped working halfway through. But I just wanted to chime in and just remind folks that we have many expenses to continue to run Healthcare for All Minnesota and grow our mighty organization, and do the important work of lobbying our legislators to eventually get the Minnesota Health Plan passed. And without your wonderful support, your volunteer time, your ability to join our evening calls and stay on top of what we're all working on, we also appreciate all of the monetary donations you've been able to give us. We accept all financial donations, as little as $1 and as much as you'd like to give. And so if you're so inclined to give even just a few bucks tonight, that would really help us with continuing this work in supporting the operations of Healthcare for All Minnesota. So I know I've been dropping the our donation link throughout the meeting. So you can find it in the chat. I'll put it in there again and make sure that's included in our follow-up. So thank you again for joining us tonight.
And one last thing, go ahead, Bahia. Even in these difficult times, I want to wish you a happy spring. Spring is coming. Thanks so much.
Yes, thank you again, everybody, for joining us tonight. I know we went a few minutes over, but we'll be following up via email, and make sure that you have all the content that we presented tonight, including the talking points from Lobby Day, the specific bills that we're lobbying for, and more. So be on the lookout and check your email tomorrow for that helpful information. Thank you and have a good night.